We are ready to start the new session. It's a pleasure for me to chair this session with Marek Ferenc and with Marco Zimarino, clearly. Panelists will be, I'm sorry for my pronunciation of some of your surnames, Nia Mileva, Mila Kovacevic, Christos Bourantas, Mohamed Munawar, Nikhil Parchure, Rajiv Bhagwat, and which is good. It means it's really inclusivity, no? And that's very good. So a good inclusivity of what I say, sex and ethnicity, and that's the best. That's how we should go. I mean, so the first presentation is from. I didn't see him, so I don't know if it's connecting. Ah, you are there, okay? From Yoshinobu Onuma on CCTA intravascular imaging guidance in bifurcation PCI.
Thank you for the introduction. So my talk is about CCTA and intravascular imaging guidance in bifurcation PCI. I will start with the case presentation, which was also presented at the EuroPCR this year, and that was prepared in collaboration with the group of Toulouse. So Bruno Farah and John Fajadet was also in the panel in that session. So this is the case. So 81 years old male, presentation with de novo crescendo effort angina, chronic coronary syndrome, and Canadian class 3. And there's no known cardiovascular risk factors, no previous medical history. Creatinine clearance was 64 milliliter per minute, and echo was ejection fraction was preserved, but there was a moderate aortic stenosis. Mean gradient for the moment was 23 millimeter mercury. So for this patient, if you look at the pretest probability according to these ESC guidelines, and the patient has a typical angina, the age is older than 70, and the patient is man, so 52% of the pretest probability of this obstructive coronary artery disease. And also, of course, patient has symptoms, so coronary CTA is indicated as class 1B recommendation. So in this case, CT was performed as a first diagnostic test. This is a volume rendering and maximum intensity projections. You can see that there was some calcification in the left main. I think from the anatomically speaking, this is the right dominant anatomy. And you can see that for the right coronary artery, you see this spot of the calcification. You can count 3, 4 plaque, but it's not really obstructive in this MPR multiplanar reconstruction. The FFRCT also showed that negative result. This study, the FFRCT was 0.86. So these are the non-obstructive coronary artery disease. If you go for the left system, however, there was a significant drop already in the distal part of the left main. You can see that the FFRCT of the Alaide was less than 0.5, and you see, if you look at the cross-section of the images, you can see that there's a significant calcification in the distal left main, almost 360 degree, and there was also the the circumflex ostial plaque, but it seems not too much obstructive in these cross sections. So we can see that also the dimension, proximally the left main has a dimension of the 4.3 millimeter, LAD was around 3.0 millimeter. And there is also another plaque in the bifurcation of the diagonal with some calcification. First, we calculate the syntax score to look at the indication of the PCI or cabbage. So you see that the right coronary artery, no significant stenosis, circumflex distal also no stenosis, but it is included in the left main lesion. So the point was 24. If you look at the LAD reconstruction, you can see the significant stenosis in the left main and some stenosis in the LAD mid. So the syntax score is 24. By combining these clinical factors such as creatinine clearance, ejection fraction, gender, COPD, etc., we could predict that the 10-year mortality of the after the PCI is 45.5%. If the patient undergoing the cabbage, also the mortality 10 years is 45.5%. So from the risk point of view, the patient could be treated in both ways, but because of the anatomy and after the heart team discussion, patient was referred to the PCI. So you can see that the left main ostium, there was a significant drop in the FFRCT. And we look at the angiographic view. So if you want to see the ostium of the left main, the best viewing angle was the LAO 20, cranial 30. If you want to go for really the bifurcation, then the best view is the spiral view, LAO 50 and caudal 35. So that was known before going to the cath lab of the PCI. So the strategy based on the CT was maybe the aorta is not so big, so we can use the 30 EBU 7 French. There was a significant calcified lesion in the left main distal, so maybe we need some modification of the adjunctive device such as lithotripsy or even rotablator. Working angle was already shown, so there's a two working angle, one for the left main ostium, the other one for the bifurcation. Stent selection, proximally it's a 4.3, so maybe distal is 3.0, so we could maybe use the 3.0 millimeter stent, and pot was 4.5 millimeter. We also think about the distal lesion, the mid-LAD, but this is a PCI planner based on the FFRCT. If you stent in left main, already the FFR is improved in the distal LAD. So maybe we eventually don't need to touch on this mid-LAD lesion. So that was the planning. So yeah, so these were also the consensus paper on the calcified lesion published in the European Heart Journal. So in this case, we have luckily the very good quality of the CT, so we could really see this distributional calcification, functional severity, CT syntax score. We can have some catheter selection, optimal projections, road mapping, and also we decided to go for the adjunctive device preparation before going to the cath lab. So actually, next slide is the actual case in the cath lab. So you see the some calcification on the roof of the left main, and we started immediately from the shock wave. So we did the 12 cycle of the lithotripsy, and then after the shock wave, we have seen some of the dissection in the proximal part of the left main, and we stented with the drug-eluting stent 4020 millimeter, and then after that, we went for this spiral view, which is as predicted by the CT. You see some of the complication in the circumflex, so we converted to the two stent. It's kind of the T stenting, and we just put another stent, 12 millimeter stent. Kissing balloon was performed, and the final pot was done. We are a little bit worrying about protrusion of the strut into the left main, so we did the OCT. So the next slide is the OCT. You can really see that the ostium of the circumflex was very well open. There's not so much protrusion, or almost no protrusion of the strut from the circumflex. So I think we finished the procedure. So this case just illustrates that how you can use the CT and for the planning of the PCI in this complex bifurcation lesion PCI. In this case, it was the left main, and also the indication of the PCI cabbage could be also discussed during a heart team based on the CT. So, however, once you start the intervention, sometimes you have a complication or some uncertainty in anatomy, then you have to use intravascular imaging. So our view is that in the near future, probably we don't need a diagnostic angiography, or you can eventually skip the diagnostic angiography and directly from CT to PCI or even to the cabbage. So the question is that can surgeon operate the patient solely based on the CT? So we are conducting one trial called the fast track cabbage trial, where the surgeon tried to operate the patient solely based on the CT without looking at the invasive angiography. Yeah, so the trial just finished. 114 patients were included in this study, and result will be presented in 2 weeks at TCT. The feasibility will be presented at that meeting. So if the trial is very positive, the next step is to really see this approach of the CT and skip the invasive coronary angiography. So we are planning to do this syntax 4 trial, which will be the patient in 3 vessel disease or left main plus other coronary artery disease. If the patient is randomized to the CT-based pathway, CT will be performed. Additional information such as the cross-sectional plaque, FFRCT will be provided, and her team can decide either the patient is going to the CABG or the PCI, and after that we will see the clinical outcome based on the CT-based pathway versus the invasive coronary angiography-based pathway. So this is still in design, but I think in the future, probably we will skip this diagnostic angiography. Thank you for attention.
Yeah, thank you so much. Great perspective, probably. We still have some conflict between radiologists and cardiologists. How is this solution resolved in this problem resolved in your center? Yeah. Who is looking for the data? Who is giving evaluation results? Radiologists, cardiologists, both?
Yeah, I think that's a great question. So in this fast-track trial, we included four centers, and majority of the centers, there is a kind of the hybrid cardiologist radiographer, so that they have a dual accreditation of the radiology and cardiology, and these people are part of the heart team discussion. So in those centers, there's no issue on the interpretation of the CT. And also in this trial, we also provide some analysis from the core labs. So during the heart team discussion, they can also consult the imaging analysis of the core lab as well. But you are right. I think in some of the center, there is some kind of conflictual situation between the cardiology and the radiology. And I think the future should be that we really collaborate together. And I think that during the heart team discussion, all images should be interpreted collectively with the cardiologist and the radiologist.
Yeah, but the point is that at least in some country, the CT scan has to be reported by a radiologist. Yeah. It's by law. So you have to have a radiologist writing I think in most of European countries, then we can discuss about education also of our radiologists, because that's another point.
Yeah.
Are we ready for that? Because I can tell you our experience, and I'm in Milano. It depends who is doing that CT scan. Because sometimes they come with, unpredictable result. I had the case last week. It's a diagonal. It was a suboccluded LED, by the way. So the point is, are we ready for this? Conceptually, it's great. Absolutely. It will avoid a lot of, not indicated coronary angiography. Yes. And they are very complex patients sometimes. And so you expose them to a risk, by the way. But the point is the community of our radiologists ready to do that?
Yeah, so this is the first in-man trial, and of course it's still a clinical trial phase. So I think first our intention is try to prove that it is possible and also can be done safely. And also the other point is that in this trial, we use the kind of the new generation of the CT, and also nowadays the photon counting CT and new technology is coming. So I think that will be really changing and moving target. And yeah, I don't know if it's really ready or not, but first I think in the clinical trial setting, we have to prove something, then probably the community will accept. So that,
yeah, and then reimbursement, by the way, because surgery, at least in some country, is better reimbursed if they have also coronary angiography, and that's big problem also for valve, for example. I don't know the experience of the others in the panel, how it's done in your country's coronary CT scan. It is done before procedure. It's guiding your procedure. Who is reading?
Yes, there's always a conflict. I think everywhere between radiologist and the cardiologist. A lot of cardiologists are training and certified to do CT coronary angiogram, but there are not many. In United Kingdom, we have a pathway during training of imaging, intervention, electrophysiology, heart failure, and devices. So those who undergo imaging can do MRI, CT, and so and so. But we do not have many. to this particular patient, I would like to ask you a question. I saw that you did not do any pre-imaging with OCT or IVUS. So do you think that we have reached that point in time where CT-based assessment is good enough for us to guide our procedure in terms of selection of the balloon size, as you selected balloon for cracking the calcium without IVUS or OCT imaging? So do you think that we have reached that point in time that we are confident from CT that we can take those decisions?
Yeah, thank you for the question. I think in this particular case, we decided already to use the IVL before going to the cath lab. The size of the vessel is sometimes tricky because in the CT sometimes the nitrate is of course given, but you might see some difference in the cath lab. So we might be a little bit careful, but at least for this case that we know that we need to use some adjunctive device. So that was somewhat useful in preparation of the cath lab. And for the dimension, I think, we should probably look at the angiography as well, so that it's not solely based on the CT, but
okay. Okay, thank you so much. Anyway, thank you so much. Again, congratulations for your excellent. We're going to speak about CT also in the next.
Okay, one comment only about what Yoshi has mentioned about the sizing. We have analyzed 186 vessels, much near IVUS and CTCA. We have significant difference in the sizing, so we have to be enthusiastic about CTCA, but I'm not sure that we are ready to advocate stent sizing based on CT data. We have to use intravascular imaging for guiding procedures. That's my feeling. I know that the research is happening towards that direction, but my first reaction from 23,000 matched images is that probably we need a little more work on that.
Okay. Let's move to the
I'm
next
sorry,
one.
but we cannot admit any reply, so we skip to the next presentation. I invite Masaaki Okutsu to have again a discussion about shape of calcification for PCI with a useful kit he's going to propose us. Thank you so much.
Thank you very much. My presentation is about how to evaluate the calcification by CT. And, actually, intravascular imaging is recommended to evaluate the indication of the atherectomy device. However, another important point is guide wire bias. The cross bias induced much more calcium aberration. In our hospital data, less than the 0.5 millimeter distance from the guide wire to the calcification is a good predictor of the good aberration by the atherectomy device. Calcification is, of course, have a very good important role in left main disease also. The eccentric and large calcium mass induced and the coronary shift is very easy. Actually, the intravascular imaging is recommended, and CT is not recommended for the evaluation of the calcification because the unclear image and much artifact. However, the CT has some advantage of the pre-procedure assessment and no need to pass the lesion and visualize the calcification overall body. However, the problem is how decide the calcium border from the CT image. In EBC in 2019, we had introduced a new calcium measurement algorithm by using the new formula. And this formula means by using the maximum CT density inside the calcium, from this score, that we can gain the calcium border CT density, and we can check the calcium thickness. And by using this new algorithm, last year, we introduced a 3D calcium model. And then this year, we would like to introduce a 3D virtual guide wire bias simulator. As you can see, this red line is guide wire bias simulation line. The simulation algorithm is below. The proximal starting point was placed on the center of the lumen, and the distal end point was the outside in the lumen in the curvature point. And these 2 points, between these 2 points, bias simulation line should be created, the shortest course with the latest curvature. And we'd like to introduce the 3 cases of the calcified lesions. This case had a very diffuse type calcification, and from the areocranial view, as you can see, the calcification distribution is inside of the curvature. Usually, like this distribution is thought to have a good guide wire bias. And then checking the guide wire bias simulation image. The number 1 point is the distal left main and distal left main part, and 3 is 4 is proximal mid LAD part. These 3 points have a good contact to the calcification. However, the LAD osseous part, the number 2, in this point, the simulation line is far from the calcification and near to the carina side. And checking the OCT, the left side is a pre-procedure OCT image, and number 1 and 3, 4, in this 3 image, the guide wire has contact to the calcification. However, number 2, in the osseous LAD, the guide wire was far from the calcification and contact to the carina side. And after rotablator, the number 1, 3, 4 figure can be seen the aberration area of the calcification. However, the number 2, the osseous LAD had no aberration area in the calcification, and but the carina side had intimal injury. So this result is matched to the guide wire bias simulation. The next case is left main to LAD calcified region. And this is a 3D guide wire bias simulation image. The number 1 is the distal left main, and the number 2 is the bifurcation core. Now, these 2 points had good contact to the calcification, but the more distal part, osseous LAD number 3, and the more distal part, number 4, and the simulation line is far from the calcification. And from lumen view, as you can see, the red dot line circle is a contact point. So this means this region had a good guide wire bias. And checking the OCT, the left side is a pre-procedure image, and number 1 and 2, this is the distal left main and the bifurcation core point, and good contact to the calcification. But actually, the bifurcation core had a deep side calcification. On the other hand, the osseous LAD number 3 had no contact to the calcification and the contact to the carina side. And the more distal part is also not so good guide wire bias. And after orbital atherectomy device. And then the the left main distal part had a very nice aberration, and after the atherectomy device. And however, the number 3, the inner osseous LAD, the calcification had no aberration and no aberration sign, and the carina side have also intimal injury. So this result is also matched to the guide wire bias simulation. And the final case is the circumflex osseum case. As you can see, the very heavy calcification can be observed from the left main to the circumflex. And about this case bias simulation image, in the left main segment, the simulation line is far from the calcification actually, and the bifurcation core point have a contact to the calcification, but a very short segment, and the more distal part from the circumflex ostium, and the more distal part, the simulation line is far from the calcification, and from the Riemann view, the contact point is the red dot circle. This point actually had a few calcification and heavy calcification, the more right side. So this means not so good guide wire bias. And then checking the IBUS. In the inside the left main, the guide wire was far from the calcification, and the bifurcation core point, the guide wire contact to the calcification, but the heavy calcification areas, maybe the 4 or 5 o'clock segment. So the more distal part, circumflex ostium, and the more distal part, the guide wire is far from the calcium side, and this means the opposite side. Then we decided that this segment had not so good indication of the atherectomy device, so we used the cutting bar and put a stent. In summary, we introduced the 3D virtual guide wire bias simulator in this year. The 3D guide wire bias simulator provide us not only the calcium morphology, but also a contact point of the guide wire to vessel wall. Although this prototype simulation software is still developing. However, this concept may be helpful to decide the PCI strategy before the procedures. Thank you for your attention.
Yeah, thank you so much. That's very interesting because surely we appreciate calcium from overall CT, but intravascular detection is extremely useful for planning. I have still some concern when we translate this message to rotational atherectomy, because we know from dentists that the burr is tropic towards calcium, and the high speed of the burr selective is attractive and dilate calcium. So I'm a little bit concerned about the message we give through this undoubtedly useful information about an eventual misleading message coming from the burr. I'm sorry, but we already had a few moments. I should, if you agree, give some word to our discussants. Do you have any comment? Yeah, short comment.
Maybe very short question.
Mila, thank you so much.
No, it's okay. Short question. Very useful tools that we saw from the previous presentation and this one as well. As Alaide said also already, that we are not sure how it's going to be utilized in everyday practice. This one and maybe the previous presentation with the FFRCT, it's very useful, and maybe it can provide us fast track to surgery. But how it's going to help us in before deciding to PCI, it's maybe doubtful. In my hospital, we have 4 radiologists. They perform CT scan. They're very skilled, and I can rely on their CT scan and the measurements. However, every time we use imaging when we have some doubts. But these 2 presentations are very insightful, and we're looking forward maybe to other new data.
Thank you very
Any comments from the audience? I would...
Okay, if not, thank you so much.
Thank you.
Dr. Okutsu. And we will continue the next topic, the effect of side branch dilatation, bifurcation lesion, a sub-analysis from the EBC registry, and Matteo Perfetti. Please welcome.
And he will do in the same also the second presentation, because he's a presenter of the first and second talk, so we will do 2 in a row.
Okay.
Yeah.
Thank you. Good morning, and thank you for the opportunity to be here. I'm going to talk about the result of our sub-analysis of this EBC registry that we've done in order to answer an old but still contemporary question. And that is side branch predilatation a good deal when facing a bifurcation lesion, and what is the role of the side branch disease in this context. Okay, first of all, let's have a see of what is the actual indication about from the EBC consensus paper. So when we have a complex lesion, if it does not meet the definition criteria for true complex bifurcation lesion, we should refrain from side branch preparation and limit the preparation to the main vessel only. Whereas when the complex criteria are met, we should prepare both side and main branch. So we are balancing between the risk of side branch loss with a conservative approach versus the risk of side branch dissection in a more aggressive approach. What we did is to analyze this cohort of more than 5,000 patients from 7 major coronary intervention centers that are from the European Bifurcation Club. And I focused my attention to the presence or not of side branch disease according to Medina definition, so very practical standpoint, and the side branch predilatation present or not. And I defined as a primary endpoint the side branch failure that I described as side branch occlusion, bailout stenting, and any dissection. Then I also consider a secondary endpoint as the individual occurrence of one of them. These are the map with the center from which the data are from. So basically all over Europe, more Japan and South America and Brazil. And the aim of the study was very simple, and was to understand what is the impact of the side branch disease and the side branch predilatation from an intraprocedural standpoint. So when analyzing the whole population, irrespective of the strategy, we see that just the presence of the side branch disease, according to Medina definition, is itself a strong predictor of side branch failure for each of the single outcome, and of course of the primary endpoint, that is the composite outcome. Whereas the role of the predilatation of an unselected population, so a systematic predilatation, is not significant as a predictor of endpoint, neither for a primary, neither for secondary endpoint. So we asked if something more was possible to obtain by analyzing, by torturing data, and to understand if some suggestion could come from the differential presence or not of side branch disease. So, sorry. Okay. So when analyzing the effect of the predilatation only in patients with side branch disease, we see that is actually a protective factor. So side branch predilatation in patients with side branch disease can reduce significantly the primary endpoint, mainly driven by the side branch occlusion reduction, and also with a trend for bailout stenting, but still not significant. Whereas, of course, when we analyze the population without side branch disease, we can see an opposite effect. And that means that all the primary and 2 on 3 of the secondary endpoint are strongly enhanced when a predilatation is performed over a population without side branch disease. As you can see, there is a bailout stenting as a secondary endpoint, a component of the primary endpoint. So we tried also to restrict the analysis only to patients that were treated with a provisional stenting only, in order to analyze this this outcome, and we saw that actually there is not a great difference between the data. Provisional stenting was accounted about for 90% of the overall population. And we see that the side branch disease is still a strong predictor of outcome, and the side branch predilatation is present only a difference for any dissection. So for the patient with provisional stenting, the predilatation to the overall population is a predictor of dissection, and but not for the composite endpoint, for the primary endpoint. But still in this population, if we analyze the differential effect of predilatation in patients with and without side branch disease, we can see that the data are the same of the overall population, because predilatation is still a protective, still against side branch occlusion and the side branch the primary endpoint. Whereas in patients with no side branch disease is substantially harmful for all endpoints. Study limitations are important to be underscored, of course. It is a retrospective analysis. It is an operator discretion-based data, so with the Medina definition, which are inserted input from the operator. This is an angiographic assessment with no independent core lab, and we are analyzing just intraprocedural standpoint, not a clinical follow-up. This is because the interest of the study it was to be an easy to do choice in intraprocedural context. So the study what we concluded with the study is that the presence of disease is a strong predictor of side branch failure. It is not surprising, but the role of the predilatation is opposite in patients with side branch disease, and that the predilatation reduces side branch complication, whereas it is clearly harmful in patients without side branch disease. So the predilatation is not should not be recommended as an unselected basis because of the increase of risk of side branch dissection, also in the provisional strategy. What we try to do is to propose, to discuss a possible approach to implement this data and the utility of side branch predilatation in a real world, because our data are from real world. And we propose a stepwise approach that is what I'm actually using in my cath lab. And it starts from two concepts. The first one is not new, is a main branch aggressive predilatation. And this is the function to help to foresee the behavior of the plaque toward the side branch ostium. So to emulate the effect of the stent before implanting it. And then on the basis of the result that we can obtain from this, we can use a side branch optional predilatation according to the result. So the algorithm that we propose and that may be interesting to study, and we have no still data about it, is to use a so-called main branch aggressive predilatation and then observe the side branch stenosis, the residual stenosis. And if stenosis and TIMI flow are good, we can proceed with the provisional stenting according to standard protocol. Otherwise, we can proceed with side branch optional predilatation that should be done gently with a semi-compliant balloon with a size to balloon vessel less than 1. And after the predilatation, we can still continue to provisional stenting if the result is good, or in case of an adverse event, we can still switch to a two-stent upfront strategy first. if the result is not still good, we can continue with a more aggressive side branch predilatation, for example, using kissing balloon inflation or a non-compliant balloon near to 1-to-1 ratio, and once again do the same evaluation that can let us to proceed toward the provisional stenting, or with a shift to a two-stent upfront technique with a side branch first, or if the result is still unsatisfactory, we can still choose the provisional stenting by using, for example, some technique to protect the side branch, just like the gyrate balloon. This is just images from my cases to show how our protocol works. This is an heavily calcified mid-lug lesion that has been rotablated with a 1.5 burr. And after the rotablating, I performed the so-called main branch aggressive predilatation, and we can see on the right the flow is severely hampered in the diagonal branch. So I performed then a two-step predilatation of the side branch with a good partial result. And then I proceeded with a standard provisional stenting with gently implantation of ADS, pot rewiring, post-dilatation, and kissing balloon, a new pot with a good final result. So what is the point? This is an approach that is very simple, easy to do, does not need new other technique, other costly technique, and it can help us to proceed with provisional strategy and to postpone the choice of the stent implanting technique. Because angioplastic is not only the stent implanting technique, so we can proceed with a correct preparation of the plaque and then to choose the stent implantation technique. Thank you.
Just go. You can move now to your second presentation, then we discuss.
It's the overall, because I show the data about the effect of the predilatation and the effect of the predilatation according to the presence or not of the side branch disease.
So you put together the two presentations.
Yeah.
By the way, you did a great job because you did it very quickly, and now we have a lot. We have 11 minutes for discussion, which is very, very good.
Yeah. My first question to you will be: could you explain again for everybody what do you understand under aggressive predilatation?
Yeah, of course. For an aggressive predilatation is essentially, ideally, a 1-to-1 balloon to vessel size ratio with a non-compliant balloon at high pressure. This is an example.
What do you mean high pressure? High pressure is for me 20 plus.
Yes, 20 atmosphere. This is what I've done on the left is a non-compliant balloon 3020. In order, and ideally we have to choose the same size of the stent that we plan to implant. So if we plan to implant a 30 stent, we will use a 30 non-compliant balloon at a very high pressure, so 20 or more, in order to emulate the effect of the stent. This is the concept.
I think this is very interesting. So it means we just predilate and then think how we treat the patients with single or double stenting, right?
Yes.
Not
right.
a priori.
Yeah, the idea is to postpone the choice of stent implantation technique after the predilatation and maybe side branch predilatation. So they limit the use of side branch predilatation to the case where it's necessary, because we have seen that side branch predilatation may be useful when disease is present or harmful otherwise. So to limit the use of side branch predilatation, to optimize the preparation of the plaque or of the wall bifurcation, and then to choose for the best stent implantation technique. This could improve also the planning for stent implantation, because we can choose a side branch first, for example, if we see that we need a two-stent technique.
So finally, if we follow your strategy, what do you personally believe? Would we have in the future less double stenting procedures or more?
I think less double stent procedure, because the goal is to increase, to limit the use of harmful maneuver. So for predilatation and to limit the number of stents implanted. So maybe also the drug-eluting balloon can find a role in this case.
But you know, how did you define then? Because this is a retrospective analysis without a core lab. So we are trusting on whatever the people inserted in an Excel form and sheet.
Yeah,
so what was the definition of, I mean, because what is side branch disease?
Yeah, what I used is exactly an operator-based definition, because the operator is the person that performed the angioplasty. So what the operation thought that about that side branch. If the operator considered the side branch disease present, he could have the choice to perform a technique
So
like
it's
this.
just 1 in 0 if it's diseased. You didn't give a definition of disease of the side branch.
No, I have not other definition more.
So it's just they had to fill in disease 1,
yes,
0, which is an heterogeneity of disease, because you can have focal stenosis, you can have long lesion, you can have whatever.
Exactly.
So these are extrapolation, most probably, and
it's very maybe a very rude approach to define a side branch disease, and actually it is. But at the end, dichotomic definition is our work, because we decide
no,
to
but
do
the
not.
inside branch is not dichotomic. We have learned that is the length of
length,
the disease,
okay.
for example. So if you don't insert the variable length of the disease, this is not contemporary definition.
Okay, so actually with a length more than 10 millimeters, actual indication of this of the paper, of the consensus paper, is maybe to prefer a two-stent approach.
It's before the consensus.
Yeah.
But okay, but this is hypothesis generating. We can work on that. There is any question?
Manuel.
From?
Manuel.
Yeah, congratulations for your result. I have two questions. First, you mentioned side branch dissection after predilation. You have data about what type of dissection? Because you have A, B, C, D. In our randomized trial, most of the dissection were type A, so not important, but
No. We unfortunately we have not this kind of data in the database, so we can't get more detailed analysis about this. But we have, on the contrary, some data about the incidence of the dissection-driven bailout stenting. And we can see that about one half of bailout stenting, less than 40% of bailout stenting are driven by a dissection. But if we consider the dissection alone, we just have this dichotomic data without further definition about AC, BC, or flow limiting.
And the second question is about in the philosophy of provisional stenting, how many patients were treated with side branch predilation and one stent across the bifurcation and nothing else? So it's super simplified technique of the provisional stenting.
Sorry, I didn't catch the. Can you repeat, please?
Yes. How many patients were treated with side branch predilation and one stent across the bifurcation, and nothing else?
Okay, these data are available. The patient treated with side branch predilatation and provisional stenting with one only stent is present here. So about 1,000 patients were treated with the predilatation in the presence of side branch disease, and 1,014 with a predilatation with no side branch disease. So about 1/2 of the patient was treated with predilatation in the population of provisional stenting, well, about 1/2. And the if we consider the provisional stenting, the majority ended the procedure with a one only stent, because bailout stenting was present in about 4 to 6%. So
Okay, there's one more question, please.
So based on this data and the case you presented, the diagonal already had disease, so why didn't you predilate that first? And secondly, the second question is, in side branches, particularly in calcified vessels, have you had any experience using scoring, cutting balloon, the ostium of the diagonal, for example? So the two parts to my question.
You are talking about the case I presented?
Yes.
No. So the case I presented, I treated first of all with a rotablator in the main branch. Then the predilatation was made first with a semi-compliant balloon 2O with gentle pressure with no success. Then with a non-compliant balloon at less than 1:1 ratio, but it was a 2.5 balloon to a 2.7 vessel at 14 atmosphere. And then was efficacy. I didn't use a cutting balloon, any cutting balloon or other technique.
Okay, one more.
Yeah, very interesting data. So I find it really interesting and fascinating that such a high proportion of patients with no side branch disease underwent predilatation of the side branch, more than half of the patients. And it makes me wonder at what point of the procedure in your database was the predilatation actually performed. I assume it had to be after the predilatation or perhaps aggressive predilatation of the main vessel, in which case those side branches that were subsequently predilated were already found to be problematic. So they're already at higher risk, if you understand what I'm saying. Maybe not.
Maybe not.
Yeah, but this is the retrospective.
So who would, it's retrospective, I appreciate that. So I mean, how many in this room would predilate a side branch with no disease?
The proportion was not too high.
It's high proportion.
Donc side branch predilatation was performed in the overall population. We consider in 400 patients, 10% of patients.
That's more than 10%, right?
440 patients were predilated. No, maybe I inverted some data.
But there were other numbers in the other slides, so I'm a little confused. I'm a little confused about the numbers.
Okay,
yes,
whatever.
Yeah. Anyways, the point being
the point is why they predilated the side branch in the absence of disease. We don't have this information from the file. I can just imagine the use of kissy balloon predilatation or a sort of protection, but we have not this data. The proportion of this patient with predilatation, no side branch disease, was actually about 10% of the overall, and we don't know why. We don't know the indication of a predilatation of this kind.
I think most of us would predilate the main vessel
we don't
first.
have the information, so we cannot answer. I think we don't have the information. Unfortunately, this was a big effort from investigators that filled in this big Excel sheet with limited data. The last question, and then we have to close.
Did you find the need for a kissing balloon inflation to optimize the side branch result when you dilate the side branch and there's a dissection?
The side branch balloon for the kissing for the side branch is of course an option for side branch predilatation. Is maybe a more aggressive approach to predilate, but maybe sometimes more effective. Yes, it's
for a small dissection, your kissing would possibly be an answer.
If I have a dissection, sorry, if you have a dissection to predilate after a dissection, if you have a significant dissection, maybe we consider to shift to a two-stent technique. So predilatation, if in order to prepare for the stent implantation, not just for leave the dissection on
so
site.
thanks. I mean, for all these data analysis, it's a big database and the effort done. Clearly, it's just hypothesis generating.
Yes,
so thanks
of course.
for your presentation.
Of course.
So we will move to the next.
Thank you so much.
The next one.
And the next one is going to be online, I think. It is going to be Shengxian Tu. I don't know if it's present online. It's connected. Okay. Hi, hello. Welcome to EBC.
Thank you. Thank you for giving me the opportunity.
Please proceed to your presentation, which is Fusion of OCT and coronary angiography for the assessment of computational physiology in side branches after main vessel stenting. So please.
Dear Chairman, thank you for the invitation to present at EBC 2023 meeting. The title of my presentation is Fusion of OCT and coronary angiography for the assessment of computational physiology in side branch after main vessel stenting. This is my disclosure. Early study from Korea demonstrated lower gel side branch FFR was associated with long-term clinical outcome. However, to measure FFR in gel side branch is technically difficult, and there was also safety concern. We proposed the angiographic-based QFR to calculate FFR from angiographic image. The first generation was based on two projections, and second generation we call it mu QFR or mu-FR. The QFR can be computed with a single angiographic projection, and with this step-down reference diameter, which is expected to improve the accuracy of the computation. So how does the single-view QFR compare to the 3D QFR? So this recent study, we used the reference projection to calculate QFR from one of the projections, we call it mu QFR1 and mu QFR2, and we also perform the most certificate 3D reconstruction using the main vessel with all the side branch and calculate QFR because 3D mu QFR. So using FFR as the reference standard, as you can see that single view QFR either calculated from first projection or second projection has comparable diagnostic accuracy compared with the 3D mu QFR. So there's almost no difference there. We further confirm the accuracy of single-view QFR in the recent post-hoc analysis using the flavor study population. So in paired blind analysis with mu QFR and FFR, we found that the accuracy of single-view QFR was 90% in 877 vessels in the flavor study population. The technology has been used to perform the physiology assessment after left main bifurcation lesion stenting. As you can see that we found that after PCI there was still a significant patient, 13.2% patient have a residual ischemia either in LAD or in circumflex. And the residual ischemia was significantly associated with worse 3 years clinical outcome as demonstrated in the figure here. Another study recently published by Professor Chen's group also demonstrated after left main LAD crossover stenting, lower post-PCI QFR was associated with a 5 years target lesion failure as demonstrated in the figure here. Nevertheless, angiographic exposure of side branch OCT can be challenging after main vessel stenting. So the main vessel OCT allows evaluation of side branch OCT with higher accuracy. Therefore, combined angiogram and main vessel OCT derive side branch OCT information is useful for side branch QFR computation. So propose a methodology to calculate FFR from the combination of OCT and angiogram from co-register data. So we automatically co-register OCT with angiogram. And using the combination of OCT and angiogram, we can calculate the new QFR. We call it OCT modulate mu QFR or OCT mu FR. As you can see the figure here, so this segment has OCT pullback. We are using OCT, and those segments without OCT pullback, we are using the angiogram. So we combine them to calculate the QFR and obtain the OCT mu QFR. So in the recent predilatation study, we demonstrated indeed OCT modulate mu FR at the highest diagnostic accuracy was slightly better than the angiography-based mu QFR, and both were substantially better than the OCT derived air stenosis or QCA derived diameter stenosis. So how about the side branch physiology co-assessment? After the correlation with OCT and the angiogram, we can further angulate and bending the OCT image so then it can be fused with the angiogram. As you can see from the figure here, you can appreciate the side branch ostial in both modalities. You can see the angiogram side branch is exactly overlapping with the OCT side branch. In this way, you can visualize the accuracy of the fusion between the two imaging modality. And after that, you are using the combination with OCT and angiogram to create a hybrid model. And this model you can further use for the computation. This slider further explains the step for the OCT mu QFR for side branch assessment. So after you bend the OCT image, for the side branch, we actually reconstructed this small cut plane perpendicular side branch center line. And based on the reconstructed image, we can further delineate the lumen contour from this cut plane and use them to fuse with the angiogram. So then you can have the side branch ostial information from the OCT in combination with the distal side branch information from angiogram. And then you can further bend them and calculate the FR from the combined model. So this is still working in progress. Ladies and gentlemen, in conclusion, angiographic derived physiology provides significant prognostic value in patients undergoing bifurcation PCI. The clinical add value of fusion of OCT with angiogram for side branch physiological assessment need further validation. Thank you. Thank you for your attention.
Thank you so much to you. This goes in a nice direction together with the previous talks about localization of the plaque and integration with multiple images going in the direction of a spatial assessment and physiology together. I would ask if you, from our panel of experts, would have any comments or questions.
I have a question.
Oh, sorry.
I have a
Yeah,
question
sure.
to Dr. Tu. Do you have any gray zone? So which value will be a borderline? Then you say, okay, we have to go with invasive FFR, whatever.
Very good questions. Indeed, I think that as the angio-based or the imaging-based FFR, there are some numerical difference with respect to the wire-based FFR. If you want to adjust want to define the gray zone, I think it's close to the 0.80. So if we have far away from the 0.80, then it's clear. In our experience, that we need to look at the standard deviation of the numerical difference. So typically the angio-based, the standard deviation is about 0.6 or 0.7 in some system. Then you can try to escape or try to see that it will make some clinical discordance in the diagnosis. But that's the same for the wire-based FFR. So if you measure the wire-based FFR again, two times, then you also have some deviation. And deviation, the numerical difference is slightly smaller. So that I cannot make a conclusion that within this range, then you can make a clear clinical decision. There was some data from, I think, from Newshome in the Favor 2 Europe and Japan study, and they analyzed them. If I remember correctly, I think it's below 0.76, then the decision will not be changed. But if it's above 0.76 to 83 or 84, then the decision can be changed within this. You can define this one as the gray zone for the angio-based FFR.
Okay, thank you.
Salven, it's Christos. Very, very distinct work. And I'm start getting more and more, let's say, flexible in using these technologies, considering the fact that in the gray zone, whatever you are using, 0.75, 0.85, there's no clear prognostic benefit from the FFR. So even if you are just have 0.83 from the FFR and 0.78 from the QFR, it does not make much difference in terms of outcomes. The question that I have, you moving to OCT physiology derived in the bifurcation lesions by taking information from the OCT, by taking the OCT to the side branch, correct? Or you doing the OCT only in the main vessel and you're trying to get the QFR from in the side branch? You take the OCT to the side branch, correct?
Yes, that's correct. So we take the OCT oxtile or side branch oxtile from the main vessel OCT pullback.
I see. So in that occasion, how you are confident that, let's say, 3-4 millimeters downside away from the ostium of the side branch, you are capturing the information by having the OCT in the main vessel? This is only for very ostial lesions, isn't it? You cannot extrapolate that to longer lesions in the side branch.
If it's long lesion with the angiogram, and normally the angiogram, the difficulty is just at the side branch ostium. I think the beauty of combination with the OCT with angiogram is that you can use the OCT main vessel with the side branch oxtile from the OCT main vessel in combination with the angio side branch. Because if you 3 millimeter distal to the side branch, to the oxtile, then the angiogram can be used for the combination.
And how you account the difference in the diameter? Because the angiography, the diameter in angiography is different from the angiogram in the OCT diameter.
Very good question. So this is a technical, small technical detail. Indeed, the imaging modality or both two imaging modality has already difference in the sizing, as you point out. So in our algorithm, we try to estimate the systematic difference and try to correct them.
Okay, thank you.
Okay, thank you so much. Thank you to you, Dr. Tu. Many greetings. Thank you for discussion. And we go ahead with presentation of Manuel Pan. Manuel, welcome. So your topic will be gel pressure wire technique for coronary bifurcation lesions, structural damage and clinical outcomes. Welcome.
Good morning. My conflict of interest. In this slide, you can see our publication about the gelled wire technique. The story started almost 20 years ago with a brilliant idea from Alfonso Medina that proposed to gel the pressure wire in 2001. This was a presentation in the European meeting, but nobody cared about this finding, even us. So we forgot this finding and continuing several years later studying the damage produced by the stent in the gelled wire. In 2015, in Revista Española of Cardiología, we published the first study that defined the degree of damage of the wire and also provide information about the sample size to design a randomized trial comparing polymeric and non-polymeric wire when these wires are used in the gelled position. This study was published in JACC in 2016, but the most important thing was that recently the brilliant idea from Alfonso Medina was resuscitated, and we used the pressure wire
in agile position in order to monitorize all the process of the treatment of bifurcation lesion with provisional stenting. At this time, we use a new technology, new wire, new index, and publish a pilot study in JAK intervention. And now we continue increasing the number of included patients and compare this data with an historical study with the study published previously in JAK, and is the presentation of today. The aims of this comparison was to compare the structural damage of pressure and non-polymer coated wire after geled wire technique, and to evaluate the mid-term clinical outcomes of patients with bifurcation lesion treated by IFR guided versus angiographic guided. We use for the study the Volcano Berrata. It's not the last generation, but in this case, you can see that the wire have a sensor, a pressure sensor, 30 millimeters from the tip of the wire. The last part of the wire is a hydrophilic, no polymer coated. The method is summarized here. Single center, non-randomized, prospective study enrolling selected patient undergoing PCI of bifurcation lesion whose provisional stenting was the use strategy. As a control group, we select the cohort of patients randomized to non-polymeric coated group from the previous mentioned study. And for the comparison, we applied a complicated statistical method, a propensity score, the inverse probability of treatment weighting. I am not an expert in statistics, but seems to be the correct method for adjust baseline difference in variable. After the procedure, we analyzed the microscopic damage and we registered the clinical outcome. The procedure is summarized here. It's a normal provisional stenting, but at the beginning we place the pressure wire at the side branch to obtain a baseline IFR. The main vessel stenting was implanted with a regular technique with POT. And immediately we perform a side branch evaluation of the physiology using the IFR. If the IFR was negative, we perform a pullback of the wire in order to evaluate the possibility of drift. If no drift and the IFR was negative, the procedure finished. And if no drift and the IFR is positive, we continue with side branch post-dilation. So in this series of patients, we have not implanted a second stent because we don't need it. The baseline data is summarized here, a lot of data, but the most important is a baseline difference between both groups that have to be adjusted by the propensity score method. We observe differences in clinical presentation, in Medina classification, main vessel and side branch characteristic. Here you can see the result of the statistical method, and the main variable for microscopic damage and for clinical outcome were weighted. And in green, you can see the weighted represented the standardized mean difference that all after the adjusted, after weighted, are within the 10%. So seems to be that this a good adjust, and we can proceed to the comparison despite the baseline difference between variables. Here you can see what we did. So I can see the numbers, but the most important is the the complication of drift. In 7 patients after the pullback, we observed the calibration of the wire and needing a new recalibration and a new side branch wiring. So if drift did not occur and IFR was negative, we finished the procedure. On the contrary, if the IFR was positive, we have most of the patient was treated with this super simple strategy. But if IFR was positive, we need to rewire and perform kissing and again perform a new IFR measurement. In this series, we didn't need a second stent. And here, in this slide, I'll summarize the results in terms of microscopic damage. We observe a difference in terms of damage. The pressure wire was more frequently damaged, but only in the distal part. The sensor wire was not damaged, and the wire could be used for rewiring in case of drift. The clinical outcome are summarized here. The first finding is that a reduction of side branch intervention. So the procedure was simplified with the use of physiology, with the use of the yellow wire, needing less intervention the side branch, in this branch. And on the right, the incidence of MACE 2 years without any significant difference. So we can summarize the result that less need for intervention at side branch and no difference at MACE at 2 years. So our conclusion are summarized here. The use of the yellow pressure wire technique could simplify the strategy of provisional stenting, although a small proportion of drift was still observed. We hope that the new modification of the wire simplify the technique. Volcano pressure wire was less resistant to yelling than conventional non-polymer coated wire. However, severe damage was anecdotal and distal to the pressure sensor. The use of the yellow pressure wire technique resulted in fewer side branch intervention. And finally, MACE rates were similar between the IFR-guided and angiographic-guided group after 2 years follow-up. Thank you for your attention.
Yeah, very interesting data. So do you believe you simplify the procedure now?
No, in a big group of patients, yes. Because if you have not drift, if you have a negative IFR, you finish the procedure as a non-bifurcation lesion. But we are waiting for an improvement of the technology in the wire. Now the OmniWire is a next generation that is recently acquired in our hospital, and we are studying the new one in order to. The key point is not to have the drift, because if you have drift, you have to start the procedure at the beginning.
Yeah, there is one more question from the audience.
Maybe I missed it, but did you do POT, and was POT performed before you did the FFR, or
yes.
how's that?
Yes, POT was recommended performed in 70% of the patient, but was a strong recommendation. We performed the IFR measurement after main vessel stent implantation plus POT.
What was, what was the distribution regarding the bifurcation lesions, like Alaide diagonal, left main, RCA? How many of? I didn't see.
You can see this is a very busy slide.
In the term of side branch, whether it is diagonal or maybe.
You have over here. I can see the data.
The answer is on the slide.
In the middle, no?
Yeah. Okay.
Okay.
Okay. So now in the middle you have more or less low proportion of left main, and most of the patients had Alaide bifurcation lesion.
Yes,
Yeah.
I
Okay,
mean,
thanks.
it's normally. I mean, I would like, before the other question, first of all, to congrats for all the work that you did in the past and you're still doing. And I mean, when we have a pillar as you are in the field, we have to acknowledge. So that's a thank for the
Thanks.
community to you
Thanks.
for all the work.
Thanks.
And also having reminded us, Professor Medina, I mean,
Yeah.
so that's important. Sometimes to stop and acknowledge what is the past, I think is important. So the next question.
Manu, congratulations for the excellent presentation and interpreting the data. Just one question that I wanted to ask. There is data that the optical fiber pressure wires have a tendency to have an extreme low drift at the end of the procedure, even if you have to cross stents once again or multiple times. Do you intend to have maybe absence or COMET for next future studies for at least trying to have less metal in the side branches? So that would be just one question. It would be very interesting to see and be part of that.
Now we are evaluating the next generation with the same protocol. I don't know. The company say that the possibility of drift in multi-vessel disease and with several use along the procedure is lower, but it has not been tested in bifurcation lesion with in a yielded position.
Okay, thank you so much. And always going in the direction of a memory of Professor Medina, we invite Stanislav Bartus to make his presentation. Thank you so much,
Thank you.
Manuel.
Thank you.
And I have a small task because Goran reminds to me and to all of us that at the end of the presentation, before going to lunch, we have to stay here because here will be done the picture of this year EBC meeting. So Stanislav, please let us go through this revisitation of the Medina classification with physiology. Thank you so much.
Thank you very much. My presentation was intended to be a just case presentation as an illustration to the previous lecture. So a few words how we did our patient. The patient was 82 years old gentleman who presented to regional hospital due to pulmonary edema and non-STEMI with ejection fraction 12 measured in echo. That was the first presentation of coronary heart disease in this patient. Patient was never treated for any cardiovascular disease before, just penis cancer treated 10 years ago successfully. And I move forward. Oh, yes. And they, in the regional hospital, performed coronary angio. Right coronary was occluded without any possibility to reopen it, which was later confirmed by experienced CTO operator. And the bifurcation of left main and Alaide was involved, as well as the ostial left main. So patient was sent to our institution to check viability of the left ventricle, and despite of some segment of the basal, middle, and anterior part of the interventricular septum, everything was viable. So patient was sent to the heart team with Medina 111 in left main and diagonal Alaide diagonal 100 probably, and the heart team qualification was to PCI with left ventricular assist device. So my strategy was to avoid two-stent technique if possible, because patient has very low ejection fraction, what means very high thrombotic risk in this patient, and keep, of course, everything open if possible. So first we started with checking what is really critical, and we found that unfortunately diagonal branch and circumflex artery were critical. So we started with orbital atherectomy because I believed that removing the plaque will help me to decrease the volume of the plaque at the ostium of the diagonal branch and circumflex artery. So probably I will not have to stent these two arteries. After that, we performed the OCT, which revealed widely open circ and widely open diagonal branch. However, in some places, this calcium was not cracked properly, which you can see here with non-properly opened balloon during the predilatation. So we had to escalate to intravascular lithotripsy, and now you can see very nicely cracked everything in this Alaide. So we sized the Alaide and sized the left main in the OCT and put the Science Sierra stent to Alaide as well in the left main, post-dilatate with 5.0 balloon, which was even oversized, kissing, and then again 5.0 post-dilatation. This is the worst angio after this stenting. You can see some disease in the circumflex proximal. So we put again the wire that was on the table, and you can see, unfortunately, 0.73. So we had to stent this circumflex ostium and proximal part of it with the same wire. So again, kissing, again, repot, and OCT showed that we covered the ostium. We also properly opened this stent. Also in Alaide, it was nicely opened, the stent, and OCT showed that the ostium of the circumflex was widely open. So we checked the Alaide, and we checked also the circumflex, which showed that DPR was almost 1. However, I was not able to rewire the diagonal branch, and at this point I decided not to close it, and that was the final result of this procedure. Because there is completely no correlation between coronary angiography and the functional assessment of bifurcation lesions, and there is strong correlation between FFR and especially in the prognosis, correlation of the prognosis with FFR, especially in the circumflex artery, jailed circumflex artery. So it is really important to use the physiological assessment of the bifurcation. However, this case was to show the balance between the indication to reopen or to open small arteries and the further risk of the complications like the stent thrombosis. Thank you for your attention.
Yeah, thank you. Very well done case. How was improvement of LV function? Did you observe some improvement after revascularization?
Not yet. Patient was not released from our hospital yet. It was 5 days, oh, maybe more a case, 10 days case.
Thank you so much for this extremely updated case. There is some question also from Mila.
Okay, thank you for a great presentation and great case. I was wondering, maybe this would be the straightforward case for the off-pump Lima LAD, for example. It's 12% ejection fraction, and as you already performed the coronary physiology, maybe it would be like the nice case for very skilled surgeon like Limala.
But the patient is 82.
82. Okay.
How many surgeons operate 82-year-old? In my hospital, no way. So just by hand, how many in your surgeon are operating at 82? Okay.
Yes, in our hospital, when you ask...
5% of the total, okay.
But, yeah, I agree, I didn't...
With 22% of LVF and 82, I mean, I think it's very... I mean, I would love sometimes, I mean, they refuse even much better patient, even 50-year-old with 22%.
Sometimes they operate patients even older, but not with so low ejection fraction.
Anyway, I didn't notice the age of the patient. However, you performed 3 DPR, yes?
Yes.
Alaide, circumflex, and the diagonal. But the diagonal is going to be influenced also by the proximal Alaide and the left main. So maybe the DPR from the diagonal is not so useful at the beginning. Yeah. Do you agree?
Yes, I agree. And there is no slide because the intention was to be short. However, in OCT, there was widely open the ostium of diagonal branch. But unfortunately, after stenting, I was not able to rewire it again. So,
no, of course, I agree with the technique, everything, but just the DPR from the diagonal maybe was, in my opinion, humble, unnecessary. That's just was my point. I
mean, anything has to be adapted entirely to the patient. This is a patient coming with a pulmonary edema, non-ST elevation MI. I mean, and that's the point. Do you have a threshold of age, for example, for Impella? Because again, 82, honestly, even if we are the larger user in Italy, one of the largest in Europe, 82 would be a cutoff for us. I mean, we don't implant Impella more than 75 usually. So that's interesting. Do you have a cutoff of age, or indeed it's the clinical indication of the patient? You evaluated well the vascular access?
Well, if the survival is longer than 1 year, we believe that it is worth to revascularize. The same situation is with TAVI, where we use, because I understand your point about the vascular complications. However, in TAVI, even we sometimes use bigger bore puncture. So
that's an elective procedure. This is a urgent procedure. So elective means you did a CT scan, you evaluate the access, and not all the 82 are treated, are the ones that are feasible for treatment. So did you check for the vascular? Did you do a CT scan on this patient?
We do. I was not presenting it here, but we, for all the patients, we do CT scan. If there is no access in the iliac arteries, we go through axillary.
A comparison with TAVI is extremely correct, I think, because there we spend much more.
No, but that's an elective procedure. This is an acute, so sometimes you don't have time to do all this.
Yeah, I will end this session with a joke, but it's a new I would say, recommendation from the EBC. When it's simple, you do provisional. When it's complex, you do decay crush. When it's a catastrophe, very complex, you do provisional. Thank you.
There is still?
I'd probably like to close with his statement, but I have that extrapolating on Alaide's comments, extraordinary case. I'm not sure about the appropriation of funds, at least in our setting. This would be way too costly. I mean, I don't know if this is something that you can afford. We certainly cannot.
The major issue was the impel, I think. But without an impel, this procedure could not be done.
No,
definitely. Also, Alaide.
I mean, we cannot say it could be done. I mean, I'm a believer, clearly, but we don't have the data that says it cannot be done. So by our personal experience, we will feel, let's say, much more comfortable to have an impel on board, but we cannot say we can be done or not.
Randomized study, Protect 4 studies ongoing, so we will
so we don't have
we will have data in the future. Thank you so much.
Thank you.